Hi, Antonio.
Hello, how are you?
Hi, I'm good, thank you. How are you?
I'm fine, thank you. So
Good. Shall
thank you
I
very much
share
for
my
joining.
screen?
Yes, I'm going to stop my share perhaps to allow you to share your screen.
Just close this, close this.
Yes, we can see it.
Just to make sure they're working.
Yeah. So just don't forget to share it when you start speaking.
Yep, okay.
Yeah,
So
because
do
usually people
pause
tend
share.
to forget. But all
Okay,
right, I can tell you, but it's better
no
if
problem. So how many delegates do we have?
we have over 100 registrations,
Okay,
107 or 8, and we already have 12 people beside us online. So I think we may have an interesting number even on the live stream. And then,
okay, no problem. That's
if
good.
you agree, we'll put it on the website of the Euro-NMD afterwards for on-demand viewing as well. So
Yep, so I've taken all patient videos away, so it should be fine to go on the website.
okay. Yes, there was that question. Yes. So I'm happy that you sorted it. Okay. All right. So I'm
Can
going.
I change my background?
Yes, if you want.
No, it's okay. I can't. That's fine.
Um, all right. So I will share your orbing slide if you stop sharing your screen. Then.
Yep, I've stopped sharing.
Okay. Thank you. Yes. Right. Okay. And we'll wait a few minutes and we'll
Yep,
start soon. Okay.
yep, no problem.
All right. See you in a minute. Okay, so welcome to this webinar that is organized by the European Reference Network, Euro-NMD, in collaboration with the European Reference Network for Rare Neurological Disorders and the European Academy of Neurology. I am Antonio Atalaya, and I work for the coordination team of the Euro-NMD as a clinical advisor. Our webinars are more or less always the same, in the sense that people are able to join in and chat between them with the chat tool. If you want to forward any questions, please use the Q&A tool that you see on the menu of your Zoom. At the end of this talk, I will start unmuting you, and you will be able to put your questions or to voice your questions if you want. Otherwise, I will read them, and they will be answered anyway. Apart from that, I just have to thank you, Dr. Sitara Ramdas, who agreed to give a talk on an update on the congenital myasthenic syndromes. She's a consultant pediatric neurologist at Oxford Children's Hospital since 2016, and an honorary senior clinical lecturer with the University of Oxford since 2018. She completed her higher specialist training in pediatric neurology and a subspecialization in neuromuscular disorders at the King's College Hospital and the Evelina Children's Hospital, London. She undertakes full-time clinical practice in pediatric neurology, with areas of special interest being neuromuscular disorders and neuroimmunology. And she leads a specialist multidisciplinary pediatric neuromuscular clinic. She's also working for the National Highly Specialized Service for Congenital Myasthenia Syndromes in the UK, and leads research and clinical trials in the pediatric neurology department. Welcome, thank you very much. The floor is yours. I'm going to stop my share, please. Go ahead.
Thank you, Antonio. Can you see my screen?
Yes, that's perfect.
So I'm just going to spend the next sort of 45 minutes talking about congenital myasthenic syndromes. We're going to cover clinical presentations of congenital myasthenic syndrome, talk about the differential diagnosis, the diagnostic clues when these children present with symptoms, investigations to consider, what are the current treatments, and future directions. Before we talk about CMS, just a reminder about neuromuscular junction transmission. We've got an impulse coming down the nerve, release of acetylcholine, which attaches to the acetylcholine receptor at the postsynaptic junction, releasing sodium, which then causes muscle contraction. The acetylcholine is then picked up by the acetylcholine esterase and broken down and taken back to the nerve to be repackaged into acetylcholine by chat. What is myasthenia? So myasthenia can be split into my and asthenia. And asthenia is really loss or lack of strength. And when I mean strength, this is weakness. In myasthenia, there's abnormal transmission across the neuromuscular junction due to an underlying genetic or autoimmune mechanism. In today's talk, we're only going to cover the genetic mechanisms of myasthenia. I think as clinicians, before I start about, it's really important to differentiate what is myasthenia and weakness and what's fatigue or being tired. Okay, because lots of patients come to us with being tired, fatigued towards the end of the day. That does not mean they've got myasthenia. You have to have objective weakness, muscle weakness, and that is myasthenia in the correct clinical context. CMS was first recognized as an entity about 40 years ago. We did a large study in the UK where we found the incidence was about 9.2 per million children under the age of 18 years. So it is a rare disorder. Most of the patients have symptom onset in infancy or childhood, but there are some late onset forms as well. How do these children present? They're typically early onset, either from birth or first year of life, of fatigable muscle weakness, involving the eyes, face, respiratory, bulbar, limb, and trunk muscles. In the eyes, they can have, and face, they can have facial weakness, particularly myopathic faces, ptosis, and ophthalmoparesis. Bulbar includes feeding difficulties. This can be present all the time, requiring NG or PEG feeds, or intermittent, in particular with intercurrent illnesses where their feeding deteriorates and then they recover and are back to normal. They can have difficulty managing oral secretions, requiring regular suctioning, or have a nasal sounding speech. The limbs and trunk, they present with gross motor delay, with normal fine motor and speech and language and milestones, can have fatigable muscle weakness, in particular proximal more than distal. I think it's important to recognize in very young children, it's very difficult for parents to pick up on fatigue. So it's only when the children are a bit older, like they're walking, running, that actually that fatigue becomes more obvious. And what was previously thought to be just floppy or weakness is more obvious to be fatigue as they get older. Neck weakness also can be associated in CMS. Finally, respiratory, they can present with recurrent chest infections, in particular requiring hospital admissions or intensive care. Episodic respiratory crisis, either triggered by intercurrent illnesses or fever, or they might have a background respiratory insufficiency or respiratory failure that they require invasive or non-invasive ventilation. So as you can see, they present with a broad range of symptoms, which can be seen in lots of neuromuscular conditions. How do we then pick out and say they've got CMS? I'm just going to cover the proteins and the common genes that we see in CMS, and then we'll go on to some cases. The commonest CMS phenotypes that we see are in the presynaptic chat, in the synaptic COL-Q, and postsynaptic, the acetylcholine receptor, in particular epsilon. Then we've got rhabsin, DOX7, and glycosylations. We'll talk about these in a bit more detail. There are several other genes which are much more rarer with smaller case numbers who also can present with CMS. In total, there are about 30 different CMS types and genes that have been reported. In our experience, the commonest types that we see are AChR, rhabsins, and DOX7. So the first case. So this was a 9-month-old infant born after an uneventful pregnancy and birth, but he had presented from the age of 4 months with several admissions to intensive care with respiratory arrest and apnea. He was noted to have bilateral ptosis, but his eye movements were normal. He also had facial weakness, and parents reported that compared to his older sister, he was a bit slow with his milestones, but only motor milestones. We've got an infant here with ptosis. Does that help us differentiate whether this child has what type of CMS? Ptosis in CMS tends to be symmetrical compared to myasthenia gravis, where it can be asymmetrical. It is fatigable. The eye movements can be normal or ophthalmoplegia. And if you've got a combination of ptosis with ophthalmoplegia, So common types to consider are your acetylcholine receptor deficiency syndromes. They're universal, that they all have ophthalmoplegia. The fast channels, 90% of them have ophthalmoplegia. And in slow channel, about 2/3 of them have ophthalmoplegia. But if you've got ptosis with normal eye movements in the picture of a CMS, common things to consider rhapsins, but the rhapsins tend to have about 80% have squint. So they have a convergent squint or a divergent squint. So check for this. DOC7s tend to have normal eye movements, as do the glycosylation. But rarely the DOC7 and glycosylation also can have mild ophthalmoplegia. This child had rhapsin CMS. What is rhapsin CMS? Just looking at the postsynaptic junction, we've got the glycosylation molecules which are important in the acetylcholine receptor formation. We've got DOC7, which interacts with MuSK and agrin. Together, they bind with rhapsin and then are important in clustering of the acetylcholine receptors, bringing them together. And this clustering is very important for effective neuromuscular junction transmission. So when there's a defect in rhapsin, there's a defect in this clustering where the receptors are not close together, they are spread all along the neuromuscular junction. How does rhapsin CMS present? It can present with neonatal arthrogryposis. They tend to have dysmorphic faces with long myopathic faces, high arch palate, and a bit of dental malocclusion. Present episodic apnea or respiratory crisis like our baby. And what's quite important is a few of these children can be normal in between this crisis without any bulbar problems or motor delay or anything. But during a crisis, they have a sudden deterioration with swallowing difficulties, respiratory problems, lose their ability to feed, have a motor regression, and then can recover after a crisis to baseline. They do really well with pyridostigmine. They have an excellent response. And the respiratory crisis tends to improve over time and is rare after the age of 5 years. And the muscle strength also improves over time. So we have some young people who have managed to reduce their medications as they've improved into teenage years and young adults. Second case. This was a 2-year-old boy. There was a history of stridor in the neonatal period. Some feeding difficulties, but didn't require any nasogastric or peg feeds. But mom recollects it was not easy to feed him. He had mild gross motor delay. He didn't walk till the age of 16, 17 months. He was noted to have ptosis, but normal eye movements. And he had fatigable weakness. So parents noticed that when he would be in the playground, running around, he would be the slowest and he would be the first one to sit down. And towards the end of the day, after a busy day, they would need to carry him upstairs, whereas in the morning, he would be able to do that on his own. And rightly, he saw a pediatrician who thought he had myasthenia and gave him pyridostigmine, but actually that made him much worse. So you've got someone with a clinical picture suggestive of myasthenia, and he had neurophysiology confirmed myasthenia, but worsened with pyridostigmine. And this child had DOC7 CMS. DOC7 CMS, what are the clues? Quite common that they have stridor in infancy, and some have well-recognized vocal cord palsy, which improves. They tend to have more axial weakness, so neck weakness, trunk weakness is much more in DOC7. And they have proximal hip girdle weakness, shoulder girdle weakness, ptosis, but with no eye movement abnormality in most cases. And they respond well to salbutamol or ephedrine and not to pyridostigmine. And we'll discuss why that happens. So, as you know, when there is release of acetylcholine across the neuromuscular junction, what happens is the acetylcholine receptors, which are next to each other, get dispersed. Okay. Following this, we've got the agrin-MuSK-DOC7 pathway, which is very important in bringing these receptors close together, what we call acetylcholine receptor clustering. And this clustering is crucial in maintaining not just the neuromuscular transmission, but also maintaining the structure of the postsynaptic folds. Okay? And when this clustering is not maintained, then the postsynaptic folds are not as good. That happens when you've got a deficiency in DOX7. And what you then get is a structural damage in the postsynaptic folds and a myopathy. Okay. So if you give these patients more pyridostigmine, you're increasing the acetylcholine here, and increasing the acetylcholine means you're causing more dispersion of the receptors and actually worsening the condition. We noted that a few patients are using an alternative mechanism using salbutamol ephedrine, which are beta-2 agonists, their muscle strength improved, and this was then confirmed by other groups as well. So you can see here the 10-minute timed walk dramatically reduced in all of these 9 patients. The 6-minute walk times significantly increased the distance, and the QMG scores came down. Salbutamol and ephedrine are beta-2 agonists, so how do they help in this condition? As I mentioned before, DOX7 joins with MuSK, agrin, and affects clustering. When DOX7 is not available in DOX7 mutations, the beta-2 agonists are postulated to interact with MuSK and find a compensatory another mechanism to maintain AChR clustering and avoid end plate myopathy. And that's how we think it works. And the beta-2 agonists work on all the defects in agrin, LRP4, DOX7, MuSK, all of them. The treatment would be beta-2 agonists because the mechanism would be exactly the same and the pathophysiology and the defects would be exactly the same with all of these 4 mutations. Next case. So this was also a 2-year-old boy. He also had mild gross motor delay. He presented in the context of a chest infection with feeding difficulties. So from previously eating and drinking as normal, he was choking on food, coughing, had nasal regurgitation. His cough was not effective. When he was seen by the pediatricians, he was noted to have ptosis, bilateral, a poor facial expression, and complete ophthalmoparesis. He was diagnosed with CMS, and I will tell you what type he had in a minute. But what was quite interesting is then his sister, who was born 4 years later, used to come to clinic appointments, and she was reasonably well, a bit slow to feed, but nothing that needed any medical input. And her eye movements, which were normal at the age of 1 month, 3 months later were noted to have some restrictions. So maybe abduction wasn't as full. 6 months, it was very obvious she had eye movement abnormal restrictions. And by 10 months, she had complete ophthalmoplegia. So she was also checked, and both these children had epsilon CMS. Epsilon CMS tends to have an early onset in infancy. They all have ptosis and near complete ophthalmoplegia, but they do not have generally diplopia, bulbar weakness, proximal weakness, and they respond well to pyridostigmine. So what happens to this? Why did the sister have normal eye movements and lose them over time? So this is the acetylcholine receptor. As you know, it has got 5 subunits. In the fetal period, we have a gamma subunit, which is replaced into epsilon subunit during the late 3rd trimester into the 1st year of life. The children with epsilon CMS, when they're born, they've got gamma subunit, which compensates for the absence of epsilon and have normal eye movements. But as the gamma is replaced by epsilon in the 1st year of life, due to the ineffective epsilon subunit, they develop ophthalmoplegia. This is a very interesting observation. What we also observed is it's an epsilon subunit, so they don't have enough acetylcholine receptor deficiency. So you give them pyridostigmine, they improve. But a proportion of patients, after we gave them pyridostigmine at higher doses, they didn't improve as well. And in fact, they got a bit worse. We looked at this with some animal models of epsilon mouse model. And these are mice who've got epsilon CMS, who have been put on an inverted screen to see how long they can hold on to the screen. So when they're not treated, they fall off the screen very quickly. If they're given only salbutamol, they can stay for a bit longer, but not that much. With pyridostigmine, they can stay for a long time. But when we gave them pyridostigmine and salbutamol, that was dramatically different, and they could stay there for much longer. So it seems like there was a benefit with salbutamol even in epsilon CMS. And why is that? When we looked at their muscle biopsies, so this is the wild type showing the normal postsynaptic junction folds. These were epsilon CMS mice, and you can see they've lost their postsynaptic folds despite treatment with pyridostigmine. So something is not going on well. There's something in the postsynaptic membrane which is not as efficient. When we gave them salbutamol, the same mice, when we gave salbutamol, they regained their postsynaptic folds. Okay, so there seemed to have been a reorganization of the postsynaptic folds after salbutamol. The mechanism we postulate is similar. So as when the acetylcholine is released, there is dispersion of the acetylcholine receptors. Okay, but what happens is over time, when we give more and more pyridostigmine, which increases the acetylcholine at the postsynaptic junction membrane, there is further increasing dispersion. And this increasing dispersion then causes a myopathy. So we used a similar mechanism as we did in DOC7 to give them beta-2 agonists to improve the clustering. And when there was more effective clustering, the postsynaptic membranes regained their previous structure and the weakness improved. So the postulation is that excess pyridostigmine causes receptor dispersion, which can then be overcome by salbutamol and ephedrine to reorganize the synaptic membranes. So in epsilon patients, when they don't respond on high dose of pyridostigmine or 3,4-DAP, consider adding salbutamol to improve their muscle strength if it's not been effective on their high doses. Slow channel CMS. So slow channel CMS is when the channel is, in simple terms, very slow to close. So this is the acetylcholine receptor. It remains open for a long time. And if it's open for a long time, there's excess calcium and sodium release in the postsynaptic membrane, which then causes damage. So this is a wild type membrane showing the really nicely organized postsynaptic folds. And this is a patient with slow channel CMS where you can see the folds are completely disorganized. Neurophysiologically, you can see with the wild type, this is the normal opening of the channels. And this is what happens in slow channel CMS, where it's prolonged opening in the mouse model. When you do electrophysiology studies, you get this typical double peak because there's too much acetylcholine in the synaptic cleft, causing this excess stimulation in the postsynaptic. How do they present? They tend to have eye involvement, as I said, with ptosis and ophthalmoplegia. They have more upper limb involvement, in particular distal, so hand weakness, long finger flexure weakness, so lots of hand weakness compared to lower limb. They have cervical weakness, and because the channels are already open, if you remember, if you give them more acetylcholine receptor inhibitors, the channels are open for longer and they actually get worse. So the treatment with them are open channel closure medications like fluoxetine or quinidine. Col-Q CMS. So Col-Q is the tail of the acetylcholine esterase here, and in the absence of Col-Q, there's too much acetylcholine here because it's not been repackaged back to the presynaptic membrane. When there's too much acetylcholine, as I said before, we get dispersion of acetylcholine receptors. When we get dispersion, we get a myopathy. So these patients present generally in the neonatal period or infancy with hypotonia, weakness. They all have ptosis, but may or may not have ophthalmoplegia. They have bulbar weakness requiring NG or PEG feeds. They have recurrent respiratory crisis, and the early onset ones will have respiratory failure requiring them to be on some sort of a long-term ventilatory support. They tend to have proximal weakness, both upper and lower limb. They're typically described to have this delayed pupillary reaction, But in practice, I must say this is seen in only very few patients. But if it's seen, it's very typical of Col-Q CMS. They also have this double peak because there's too much acetylcholine in the synapse. The treatment. So as I said before, so with acetylcholine, there's too much acetylcholine. There is dispersion of the acetylcholine receptor. And what do we do in those conditions? We use salbutamol or ephedrine to reorganize this dispersion and improve the end plate myopathy. So the two conditions to use salbutamol and ephedrine as first line are DOC7, Col-Q, and then Agrin, Musk, and LRP4 in the same pathway. So all of these salbutamol ephedrine should be the drug of choice, and acetylcholine receptor inhibitors will make them worse. Glycosylation. We know glycosylation is ubiquitously in all the organs in the body, but there seems to be a bit of an odd pattern of involvement of muscle and just neuromuscular junction. We know glycosylation is involved in the limb-girdle muscular dystrophies and congenital muscular dystrophies, but we found a proportion of patients who had typical congenital myasthenia phenotype who had glycosylation defects. And these were particularly in the N-glycosylation pathways. GMPPB is unique in that it has both O and N-glycosylation pathways. These patients present with slightly later onset limb-girdle pattern of weakness. They usually do not have ptosis, ophthalmoplegia, or any facial weakness. They have raised creatine kinase, as I described with the muscular dystrophies. The muscle biopsy shows dystrophic changes. It can have tubular aggregates, or it can be really non-specific, showing some myopathic changes. The treatment is pyridostigmine with or without 3,4-DAP. These patients can have an underlying myopathy, and that's important to remember that because that will not respond to your treatments as acetylcholine receptor inhibitors and actually can be slowly progressive. Fast channel CMS. Compared to slow channel where the channel was open for too long, in fast channel the channel is just closing too quickly. You can compare these. And if it closes too quickly, you don't have effective release of sodium, and then you don't have effective muscle contraction. These children universally present with onset of symptoms at birth or neonatal period. They have significant respiratory involvement with respiratory crisis, respiratory insufficiency requiring NIV or tracheostomy, swallowing difficulties requiring PEG feeds, ptosis with ophthalmoplegia is universal in most cases. They have significant hypotonia and muscle weakness. They respond to pyridostigmine, 3,4-DAP, with or without salbutamol. Congenital myopathies with secondary neuromuscular transmission defects. So these are children and adults who have genetically confirmed congenital myopathy, so well recognized and confirmed on muscle biopsies, but who also on neurophysiology were found to have a secondary neuromuscular transmission defect. So they had symptoms suggestive of myasthenia, but had definitely had a myopathy. And when neurophysiology investigations were done, they had definite decrement or jitter. And this has particularly been described in two types. So your centronuclear myopathies with dynamin 2, MTM1, or your fiber type disproportion with RYR1, TPM2, and 3. These patients respond to pyridostigmine, but what's important to recognize is only their myasthenic component will respond to pyridostigmine. Their underlying myopathy is not going to be cured. So you will have some benefit, but it does not cure their underlying myopathy. So they're not going to be completely treated. They will only have a partial response to their muscle weakness. And typically it's pyridostigmine that they respond to, or salbutamol. We're now finding more and more genes involved in congenital myasthenic syndromes. And these are much more smaller number of patients, but they are important to recognize that there are other phenotypes which extend beyond the neuromuscular junction. These are patients who can have other dysmorphic features, like I mentioned in Rapsin, Hall13A1, TEC1 association with epidermolysis bullosa, patients with myasthenia symptoms but have a raised creatine kinase, think of glycosylation defects. With CNS involvement, epilepsy, ataxia, EEG abnormalities, SNAP25B and UNC13. Facial tics has been described in LAMA5, kidney and eye abnormalities in LAMB2, cortical abnormalities in SLC25A1, or peripheral neuropathy like areflexia and hearing loss in SYT2, and learning difficulties in a number of CMS syndromes. I think with some of these, the learning difficulties is difficult to say, like with the chats who are known to have lots of apneas in the neonatal period, respiratory arrest, could these be more related to them having a hypoxic brain injury? But certainly with the glycosylation, or the association is now well recognized as unrelated to any respiratory events, and it's probably part of their CMS plus phenotype with brain involvement. And I think this just emphasizes that we need to be thinking beyond the neuromuscular junction, and that will be important for us to think about when we think about treatments as well, how we focus for these children and adults who have got a much more wider spectrum of symptoms as part of their CMS. Just a few clues for genetic diagnosis with symptoms. So if you've got episodic apnea in children, the 5 common ones to consider are chat, fast channel, Rapsin, SLC5A7, and COL-Q. For arthrogryposis, Rapsin, chat, SLC57, and agrin. As I mentioned before, there are some late onset phenotypes who do not have significant symptoms in the first decade of life or might have been milder. This is the slow channel syndromes, COL-Q, glycosylation defects, DOC7, and the agrin-musk are LRP4 pathways. Investigations. In a child with suspected CMS, there's probably only 2 investigations or 3 to consider. In the very typical picture with a very early onset, the first test to consider would be neurophysiology, and that includes repetitive nerve stimulation and single fiber EMG. Typically is seen as a decrement of more than 10% on repetitive nerve stimulation. And on single fiber EMG, we see a jitter or block. Few things to remember about neurophysiology. First, repetitive nerve stimulation is probably more specific for myasthenic weakness or neuromuscular transmission weakness, but single fiber EMG probably is more sensitive. Also, it's important to test in a weak muscle. So if someone's got significant eye weakness, but not much proximal limb weakness, testing in your hips and your quads is not that beneficial. It'll be better to test them around their orbicularis oculi. So make sure you speak to your neurophysiologist and specify which muscle you would want tested, and test the weak muscle. You're going to have much better yield. The next test we generally progress to is genetic testing. There are several gene panels for CMS genes, or you can do single gene testing if there's a known family history and you want specific testing. In the children who are slightly later onset, it's always important to think about antibody testing to rule out myasthenia gravis. Which comes to my differential diagnosis. So the commonest differential diagnosis is juvenile myasthenia gravis. Can we differentiate CMS in juvenile myasthenia gravis? I think in the older children who have been completely well previously, juvenile myasthenia gravis is quite a straightforward diagnosis. But always be suspicious with someone having a diagnosis of myasthenia gravis, especially with symptom onset at a very young age, so under the age of 2 years. Children who have significant ophthalmoplegia, which is static, not variable, who have ankle dorsiflexion weakness, and significant bulbar and respiratory problems with recurrent crisis. Okay? Also important to remember that about 10% of juvenile myasthenia gravis can be antibody negative, especially in young children. So not all antibody negative myasthenia gravis is CMS. Transient neonatal myasthenia gravis, you have a typical history of mom who's affected, but in about 20% of cases, mom can be asymptomatic. SMA has very, very typical features and history without any facial involvement, with distal, particularly lower limb involvement and areflexia. Congenital myasthenia dystrophy, usually there's an affected parent, usually mom, with very early onset, facial weakness, arthrogryposis, respiratory involvement, and with a family history, it's easy to diagnose. With myopathies and muscular dystrophies, I think it's always important to consider them, but they usually don't have a history of the clear fatigability. Mitochondrial always comes in the differential, and with the later onset phenotypes, think about limb girdle muscular dystrophies. I've put hypomobility syndromes in here because this is something we get referred quite a lot. Children who are hypomobile, as you might know, tire and fatigue very easily after physical activity. Okay. But this does not, when you examine them, they do not have muscle weakness. And that's really important for parents to understand. And the best way to do them is actually show them in clinic how able they are and they don't have muscle weakness after doing, making them tired by going up and down the stairs or a 6-minute walk, to show the child saying, I'm tired, my legs hurt. But actually, when you can show they have objectively normal muscle strength, that reassures the parents. Treatments. This slide just highlights the different treatment strategies that we use in congenital myasthenic syndromes. The commonest treatment is acetylcholine receptor inhibitors. These act by preventing the breakdown of acetylcholine and its repackaging back. So you've got more acetylcholine here at the synaptic cleft. And we've got 3,4-DAP, which works in similar way, but it, via the potassium channel, causes more stimulation along the nerve terminal, causing excessive acetylcholine release to increase the acetylcholine at the synaptic cleft. Got beta-2 agonists, who via the MuSK pathway influence clustering. And then we've got the channel blockers in slow channel syndromes. So how do we treat children or adults with CMS? When there's a clear genetic diagnosis, it's straightforward. When you've got someone with suspected CMS and you want to start treatment, the first question to ask is, do they have any features of DOX7, Colcley, or slow channel syndrome? If they have these features, then avoid pyridostigmine, because we know pyridostigmine will make them worse. If they have these features and you're awaiting genetic diagnosis and you need to consider a treatment early, salbutamol or ephedrine probably is your best bet. If they don't have any of these features, pyridostigmine is a good first line for all other types of CMS. And once you have a definite genetic diagnosis, you can have additionally in the pyridostigmine group 3,4-DAP and salbutamol. If in slow channel, fluoxetine, quinidine. Just touching upon, like I mentioned, what are the future directions? So we know with treatment, our patients with CMS do well, okay? But it's not a cure. They all need to continue to take the treatment. Some of them develop side effects. So can we make this better? Can we give them more effective treatments? This was a study done by Enu et al., postulating that upregulating DOX7, because it's involved in the DOX7 MuSK pathway, would increase the neuromuscular junction surface area. So they used the transgenic DOX7 mice and actually found that there was increase in the nerve compared to the wild type, and also in the AChR receptors. So they had much bigger neuromuscular junction. And looking at it, they had much more larger AChR positive area and a wider end plate. So it seems like having more DOX7 does help have bigger neuromuscular junctions. The group then followed on to do some more studies, and this was with AAV-DOX7 gene therapy in mice. So they gave AAV-DOX7 gene therapy both to wild type and also to DOX7 knockout mice. What was clear in both, we go to the knockout mice first, was when the knockout mice were treated without treatment with DOX7, they had really poor neuromuscular junctions, but when they were treated, they had very large AChR receptor areas, a larger nerve terminal, and this massive, what we call super synapse with the AChR nerve terminal. And this was in DOX7 knockout mice with gene therapy. But what was interesting is when they showed the asymptomatic wild type mice also with AAV-DOX7 gene therapy, they also had these massive super synapses. And on objective studies, the clusters were much bigger. The knockout mice survived with gene therapy much more longer, and they had better abilities. So what does this mean for the future? What we can see is that AAV gene therapy in mice does improve the neuromuscular junction transmission. But what's quite interesting, not just for DOX7 patients, if you extrapolate it to patients with myasthenia, as in with this wild type, they also have larger neuromuscular junction terminal and these super synapses, which actually could be beneficial in all patients with CMS to improve their neuromuscular transmission. So this is very exciting, and this might be something we might see more in the future of having a much more effective treatments in CMS with this model of enhancing DOX7 to improve the neuromuscular junction transmission with these super synapses. So in summary, what do we approach, or how do we approach a child with or adult with suspected CMS? If you've got a child with suspected CMS, the first question to say is, do they only have neuromuscular junction problems? Okay, if that's the case, the next is look at their eyes. Do they have ophthalmoplegia? If there is ophthalmoplegia, then think about your acetylcholine receptor. So there could be a deficiency, the commonest is epsilon, or it could be slow or fast channel, both again in the acetylcholine receptor. The clues, like I said, with the AChR deficiency, they have marked ophthalmoplegia, but they remain stable over time. The slow channels have a double C-amp and have a distal weakness in the upper limbs and neck muscle weakness. The fast channel are much more weaker with earlier onset and recurrent respiratory crisis. And the colcues also have this double C-amp and delayed pupillary response. If they don't have the ophthalmoplegia, then look at their pattern of weakness. If it's typically a limb girdle pattern of weakness, then think about your DOX7 MuSK pathway with agrin and LRP4. And if they have stridor, DOX7 would be your best option to test first. But if they have a limb girdle pattern of weakness with sparing of facial muscles and eye muscles and a raised creatine kinase, with a myopathy, think of glycosylation defects. If the pattern of weakness is not limb girdle, Rapsin would be the first one to check. But see if they've got any facial dysmorphic features, contractures, and recurrent respiratory crisis. Got chat, again with respiratory crisis, and they have a decremental response after exercise. And COL13A1, which is one of the more newer genes. These children also have dysmorphic features, in particularly skeletal abnormalities, sort of pectus carinatum. They have much more involved, scoliosis is higher, and the ptosis in them doesn't seem to be as fatigable compared to the other CMSs. If they have more than outside the neuromuscular junction, think about the other genes with CNS involvement, with EB or plectinopathy, with tics and facial dysautonomia and LAMB and LAMB5, and purple with renal abnormalities, cystinuria, and growth hormone deficiencies. In summary, CMS presents with a wide range of clinical signs, which can overlap with a number of neuromuscular conditions. So it's important to look for diagnostic clues to help you guide your investigations and treatment. important to have a high index of suspicion for CMS because there are treatment options which are available, which are not there for other neuromuscular conditions. And early recognition and prompt treatment can have a very effective. And certainly, we've had infants we have diagnosed CMS, and we know of history of a previous sibling who died with a sudden death, who probably also had CMS that was not picked up. So it's really important to suspect it, investigate, and treat them. But I agree, diagnosis can be challenging and it's not always very straightforward. Thank you.
Thank you very much, Sitara. Very eloquent and clear presentation about a subject that is complex, but I understand your enthusiasm for it because it's very geometrical. So you have the genetic and the mechanism on one side, you have the symptoms on the other, and you did a very nice connection between the three areas, and that will help probably many people to better understand and treat the patients. We have questions, which is quite nice. So there is an anonymous attendee who asks, does CMS patients also have fatigability like in autoimmune cases?
Absolutely, yeah. So fatigable weakness is typical. So if you don't have someone who has got fatigable weakness, then I would be very suspicious that's not CMS. So you have to have fatigable muscle weakness.
Okay, so that's answered. Mark Richardson, if you want to speak, just go ahead and mute yourself and tell your question. Otherwise, I will read it. Okay, so in that case, I will read it. Are you aware of any studies into the role of exercise as a treatment within CMS?
Yeah. So yes, so we actually did a very small project with one of our patients looking at exercise. And actually our physio did a very, a stage program, gave them a very intense exercise program. And actually there was improvement over time. Because what we find with lots of our patients is that deconditioning just does influence them. So if you've got muscle weakness, because of which you're not doing physical activity and you're more deconditioned, you're more likely to, not be able to do more. So certainly I think the role of exercise, we encourage all our patients to do regular exercise, not to the limit that they're fatiguing, but have a regular exercise program to prevent deconditioning. And certainly we do think exercise really helps.
Good. So another question is Pierre Tikhonov, you're unmuted. You can go ahead and voice your questions if you want.
Yes, you were talking about treatment with ephedrine or salbutamol. Is there any difference between two treatments?
Yeah. So from an efficacy point of view, no, they both work really well. What we find is our patients sometimes have more cramps with salbutamol. If you want, and the salbutamol probably works a bit quicker. So it's whatever is available and accessible, for you would be the one to go for. There's no difference in efficacy. Both of them are similar.
Okay, thank you.
So Renu Sutar, you are also unmuted if you want to put your question.
Hi, Dr. Sitara. I just want to ask, we have seen seasonal variation in children with CMS. What is the explanation for that? And second question is, what is the maximum dose of salbutamol you use for treatment of children with AChR receptor deficiency?
Okay. So the seasonal variation is very typical. So we know in the summer, myasthenia, whether it's CMS or myasthenia gravis, is much worse. So our patients, when they go on holiday to the hot weather, they always feel worse. So we know that's a known association with myasthenia being worse with hot temperatures. The maximum dose will really depend on how old the children are, Renu. So with a young child, I probably would go, 4 milligrams BD. But with teenagers, adult size, we would go to 8 BD. So it really depends on how big they are.
Thank you.
So Danielle Santirso, you can unmute yourself and voice your question if you want. Okay, so I will probably read it. So Danielle Santirso is asking if muscle cramps are a typical feature of CMS.
No, CMS, pain and cramps are not a feature of CMS. And in fact, weakness in CMS should be painless. So if you've got someone who's presenting lots of aches and pains, that is not CMS. And you should always be suspicious there whether there's something else. So myasthenic weakness is painless. But I said, patients who are on salbutamol as part of their treatment for CMS can get muscle cramps, especially hand muscle cramps.
Okay, so Xavier Lornage, if you want, you can voice your question. Just unmute yourself.
Yes, so myasthenia appearing at an older age, after the age of 80 years, may it be genetics or or is it almost all the times drug induced?
I couldn't hear that clearly. Could you repeat that for Antonio?
Yes, so Xavier is asking if myasthenia in the elderly after the age of 80 is characterized by ptosis, dysphagia, and speaking difficulties. May it be genetics is the question.
No, not at that age. So it'd be incredibly. So like I said, we've had a few later onset phenotypes, coming. But if you dig the history further, they all had symptoms in their, they were never that good at school in their teenage years. So they never come suddenly at the age of 30, 40. There's a way, they all from childhood. So I wouldn't think about CMS in a typical like gravis like picture in older onset.
Okay, Thomas Harbo, you can speak and voice your question if you want.
Okay, hi. Thank you for a very nice presentation. I have a question about a now confirmed DOC7 patients. But before we had the genetics, he responded also to fluoxetine. And I was wondering if any DOC7 mutated patients also would benefit from some of the other treatments. I know not the mestinone, but the other treatments.
So I think we know some of the DOC7 patients do respond to 3,4-DAP, though it increasing the acetylcholine receptor. This thing, we haven't had anyone responding to fluoxetine, and we certainly don't use it when we know they're DOC7. But whether the mechanism is similar to, because it's, with the slow channels, the fluoxetine you've got is restructuring the postsynaptic membrane, which is sort of the mechanism in DOC7 as well, is where that's where you get a partial response. But I don't think I would expect, if you go with the mechanism of how DOC7 produces pathology and slow channel, that fluoxetine would be, should benefit DOC7 patients.
Thank you.
Okay, so apparently we do not have any more questions. I don't know if Sitara, if you want to say anything else. I would just comment that this is a fascinating area, and as you know, variations are, as you have presented, very wide from mechanism to mechanism and from gene to gene, and even within the same gene from variant to variant. So I suppose that in the future this would be an area where precision medicine and artificial intelligence may cross their fingers and do some interesting work. What do you think about that?
Yes, no, absolutely. No, thank you. I agree completely. I think we've got treatments, but we can do better, and hopefully we'll have much better precision medicine in the future. It's all to look forward to.
Okay. Thank you very much for your participation to all. Thank you very much, Sitara, for your wonderful presentation. And as you know, this presentation will be posted on the Euro-NMD website for on-demand viewing afterwards. Okay, so thank you very much. Bye now.
Thank you for listening, everyone.